Hello Nigeria, hello Africa, welcome to yet another exciting episode of the second season of Voices for Self-Care podcast. I know we promised that this season is going to be more engaging and exciting, and on today's episode we're about to fulfill that promise. Today we'll be talking on a very controversial yet very crucial topic that affects a lot of women. In fact, a lot of women around the world, and especially in Nigeria. We'll be talking abortion and postnatal care. And we'll be having a very esteemed guest who will take us on this conversation. We're going to short break right now, and when we come back, I'll let you know who it is. We'll be right back. Welcome back. This is the Voices for Self-Care podcast. Abortion is such an unsafe word to use within the Nigerian context because of the societal stigma and legal restrictions attached to it. And this has exposed a lot of women to having unsafe abortions and restrictions to accessing post-abortion care. And this is why this topic is really important. Today we'll be dissecting the topic navigating self-managed abortion care in Nigeria, policy, practice, and legal realities. And to take us on this conversation is the country director of Ipas Nigeria Health Foundation. He has spent the last 20 years strengthening health systems' capacity to respond to different health issues in Nigeria, including HIV, malaria, and sexual and reproductive health. He is a proponent of legal frameworks that allow for the delivery of sexual and reproductive health services, and he has led various programs for Ipas Nigeria Health Foundation to ensure that the legal barriers to SRHR are removed. My esteemed viewers, please join me in welcoming Dr. Lucky Palmer. Wherever you are, give a round of applause to him. Welcome to the show, sir.
Thank you, Yari.
It's such a pleasure to have you here.
My pleasure too. You have a beautiful studio, and I can't withstand the topic, so I must come.
I know, right?
Thank you for the invitation.
Thank you so much for honoring our invite. And I'm excited about today's topic because this has always been shrouded in secrecy for the longest, especially in Nigeria. And I wanted to talk about it. I wanted to talk about the legal barriers. I wanted to talk about the loopholes, the gaps, the provisions, the advocacy efforts Ipas Nigeria is ensuring, is practically doing to ensuring access to safe abortion and also post-abortion care in Nigeria. And that is why I'm excited to have you. When I thought about this topic, I could think of no other person but you to come on the show. So thank you very much once again for honoring us. So the first question I'm going to ask you is, what exactly is the difference between abortion? For our viewers who are watching, what exactly is the difference between abortion and post-abortion care?
Thank you, Yari, for the question. Maybe first of all, I want to go back to some of the things you said on your introduction around the issue of legal. Because there's a huge myth about abortion in Nigeria legally. Abortion is not illegal in Nigeria, it's only restricted. And it's because there are different conditions that have been listed in our law for abortion to be provided. So now coming to the question you asked, the difference between abortion, that's induced abortion, and a post-abortion care. I'll probably look at it from two perspectives, independently of each other. Why induced abortion could be a cause or a reason for post-abortion care. You can also have post-abortion care induced by the nature itself.
Kindly explain, sir.
Yeah. So abortion is, so if you have a live fetus and you on your own decided to terminate it for different reasons, can never be explained or understood except for the person in that particular position. However, post-abortion care means that there was an abortion and a complication that arises from it, and then you need attention to treat. So by Nigerian law, post-abortion care are usually treated as an emergency medical procedure that must be provided, that is guaranteed for every woman in Nigeria to have. So for example, what are the main causes of the need why a woman will need post-abortion care? An average woman I doubt if there's any woman of reproductive age that have not experienced one form of miscarriages or the other. So when a woman have a miscarriage, you will need post-abortion care. And what does that entail? It means the doctor wants to examine you to be sure that all the fetus are fully expired or evacuated from your uterus. Because if not, that could lead to infection, and that could lead to sepsis, and which is already very deadly, and one of the major causes of maternal mortality in Nigeria. And by the way, just to throw that out there, Nigeria have the highest maternal mortality in the world. We contribute now almost 30% of the world maternal mortality, according to the WHO report of 2023.
Wow.
So, and abortion is one of the major causes of maternal mortality in Nigeria. Between 10 to 50%, depending on the kind of source you look like, in Nigeria are due to unsafe abortion, contribution to maternal mortality. Another area, again, for that you might need post-abortion care is women normally have instantaneous abortion. Sometimes it's the nature itself trying to correct anomalies. If the fetus is not well formed, the nature itself has a way of flushing it out, so that leads to miscarriage. And then the woman would need to be taken care of by a doctor, most are probably by a gynecologist, to ensure that our system are all right. If there's any remnant, have to be taken out, and she's probably put on a bed rest, and the right medication follow. That's what I'm saying. That so it could be unsafe abortion that lead to the need for post-abortion care, but it could be nature on itself that will try to correct the fetus, and that will lead to post-abortion care. But by and large, both of them, you talked about evacuating the uterus for the safety of the woman and ensure that the woman is still able to conceive in the future. Because if the evacuation is not done on time, there could be infection, the uterus could be damaged, and that could be the end in terms of conception for that woman. So, and that's why it is treated, post-abortion care is treated as an emergency medical procedure in hospital. By our medical guideline in Nigeria, it's usually supposed to be free, but sometimes, depending on the state, depending on the hospital, you could be asked to pay for this, to pay for that, to pay for consumables. So in the end of the day, the woman might end up spending money. But it is a life-saving procedure that every woman is guaranteed and should request for when in need.
Thank you very much, sir, for that clarification. I want us to talk about self-managed abortion. My first question to you is that even legal in Nigeria? I know you spoke about, when you started, you clarified saying abortion is restricted, not illegal in Nigeria. So what exactly is the provision of the law when it comes to abortion in Nigeria? That's one. Then secondly, is self-managed abortion permitted in Nigeria?
So the law says that abortion is permitted when it's done in good faith to save the life of the woman. But the law is not very clear. How do you determine when the life of the woman is at risk?
True.
And sometimes I ask people, is it when the woman's life is about 1 second for her to die? Is that when you say the life is at risk? Or is it when it's 1 hour or 2 hours from death? How do you determine that the woman's life is at risk? So, and that's why sometimes women that need treatment for abortion, who need abortion care services, are not provided because health workers feel, okay, their life is not at risk yet, let's watch and see whether she will survive. And then over 80% of the time, the woman will die because care or response or intervention were delayed. So the question is, when is the woman's life at risk? At what time does she deserve to be treated to save her life? So regarding self-managed abortion,
yes.
It is a very crucial services that evidence have shown that has helped to save and reduce death from unsafe abortion. So there are policies, WHO have given different advices to different countries all over the world. And it's very funny, let me come from this angle. Self-managed abortion, was discovered by women, not by medical doctors.
Right. So do you have proof of that?
The proofs are available online.
Right.
So my suppositor, which was the foundation for self-managed abortion in a way, was initially prescribed to manage peptic ulcer. And like there are different medications that one of the contraindications is that a woman who is pregnant in the early stage, it's okay, if you take this could lead to abortion or you could miscarriage. And the women in Latin America, I think Brazil, Argentina or so, started noticing that if they take my suppositor, they actually are able to abort their pregnancy. Because for years, women have always wanted to be in control of their body. And even traditionally in Africa, there are herbs that are taken to induce abortion. And that's why if you go into the history, you find out that our aged mothers, they are always able to keep 2 to 3 years between siblings. Because without using any mother contraception, because there are herbs that if they notice they have taken it when the child is not yet walking, that they will take to induce abortion. So that was the same scenario that the women in Latin America found themselves with my suppositor. And then gynecologists now said, you know what, this is interesting, and the studies were done, and the efficacy was established. That was formally adopted, and then the right dose were now discovered for different ages and different gestation. That I would say is interesting that you went to them, and it's continued from there. And then sometime later on, mifepristone was now also discovered, which is even more potent than my suppositor. And what have they really done? When you look at the available statistics, self-managed abortion have really helped to reduce death from unsafe abortion.
Right.
Because abortion itself is stigmatized. It's also self-stigmatized. So if somebody who needs abortion services, when you go meet healthcare workers, you are stigmatized. And even if the services are provided, co-workers stigmatizes you. So because of that, women always look for, where is it, how do I take care of myself without letting somebody else be aware of what I'm going through? And that's why my self-managed abortion became very prominent. And I think policymakers also realize that, you know what, how do we support these women? Because if we don't give them this legally, people will do all manner of things to get this done.
Okay, so Dr. Palmer, let's talk about the current realities we have in Nigeria. And the National Self-Care Guideline, the current National Self-Care Guideline 2020, did not adapt WHO's recommendation on self-managed abortion. And also the self-assessment of medical abortion. The only provision it has relating to abortion is post-abortal care. That is post-abortal care, and then post-abortion family planning. That's hormonal contraceptive after abortion. However, the guideline is currently being reviewed. The first review process has started to scale up to broader ranker interventions. So my question to you would be, what are the challenges do you see in integrating self-managed abortion, and self-managed abortion care into this new guideline?
Well, I'll probably start from the situation that we find ourselves as a nation and as a people. And if I'm to quote the Professor Fitula from Egypt, that talked about that women are not dying because of the disease that cannot be cured, but they're dying because society does not deem their life is worth to save.
Right.
So right now, Nigeria have the highest number of maternal mortality figures in the world, between 60 to 75,000 women every year. Some years ago, we have this one where we were having plane crashes almost every other month. And there was a critical conversation that was held nationally around the aviation safety that I helped to improve safety of aviation in Nigeria. So the question is, if we know of a fact that 60 to 75,000 women in Nigeria die every year because of pregnancy complication, different reasons, including sepsis, including unsafe abortion, including lack of access to post-abortion care. Then, can we stop it? The answer is yes. Do we have the technology to stop it? The answer is yes.
Okay.
Are we able to stop it? The answer is yes. But do we have the courage to do the needful to stop it?
The answer is no.
The answer is no. So it's that courage that I would probably want to talk about. And let's use facts to induce and push out those courage from everybody. Why are women dying from unsafe abortion? Because they're using the wrong medication, or the wrong method, or the wrong approaches, or because there is no skill. Even by where they're even healthcare worker, they are not skilled. They are not trained to provide those services.
Okay, so if that is the case, some will argue that self-managed abortion is directly proportional to unsafe abortion. Self-managed abortion is unsafe abortion. That's what people will argue.
Okay, so I was building my point earlier on, and I was talking about why do people go for unsafe abortion? People go for unsafe abortion for lack of information, for lack of access to care, or lack of access to medication, or lack of money or funding to pay to even visit an hospital.
Right.
So, insulin, at the point you have to go to hospital for every time to take your insulin, and then we move from there to self-care where the doctor guides you on how to do it by yourself. And now in this age of IT, of smartphone, of everything being available online, the medication that you can take rightly to induce self-abortion is available, it's easy to get, and has proven to be safe. But the question is, do you have the courage to allow the young girl, the married woman, to safely have access to those medications to induce abortion? The answer is no. And what is the alternative? They go to quacks, they use cassava stem, they use the spoke of anger or spoke of tires to induce abortion. And the word on the street is just tamper with the, just do whatever you need to do. If you are bleeding and it's urgent, go to the hospital, government will treat you. So you have a choice of spending so much money on post-abortal care, which is much more expensive than induced abortion or safe abortion or safe care, or educating the girls, educating the population to know where to go to get the right medication to use to induce abortion.
Right.
So it's a choice between the deep blue way or the deep blue sea.
The devil and the deep blue sea.
And the deep blue sea, exactly. Is it that we provide that opportunity, or people continue to go for unsafe and our women continue to die? And the truth is, I might be here today, I have a daughter. If I do not educate my daughter, she can fall a victim of unsafe abortion tomorrow.
Right.
So you are there, it might be whatever position you are holding. You have a daughter, you have a sister, you have a wife. She could be a victim of unsafe abortion. And then you talk to her, oh, had I known, I would have educated her, but by then it will be too late. It's very easy to say, God forbid.
True.
Right? But the reality is, it's like somebody who's traveling on a journey and say, God forbid, I will not have an accident. I'm yet to be told of somebody who's traveling, and who say, God, as I'm going, make sure the person, I want to have an accident on the road.
Nah,
but do accidents happen?
True.
Do people die? So that's the thing. So we need to take a decision. And I think for me, it's using evidence to engage in this conversation to see how we can make sure that every woman, every young girl child have access to self-medication and abortion, since not even all our medical professionals are willing to provide such services.
Willingness is the key thing here.
To provide the service. So why don't we enable the woman to have our own choice.
Okay, so
and then we can think of how do we support them to do it the right way.
Right. So I think the counter response to that would be maybe there's no so many technologies or platforms for self-awareness enough for these women to self-manage abortion. You understand? Except there is there any existing website application that women can actually go accessible, where women can access their eligibility for abortion, self-managed abortion, even medical abortion?
Yeah, so I'll mention just two quick apps.
Okay.
There's one that's called Safe Abortion app,
Okay.
Safe Abortion app or SA app. There's another one called Experian app. Both of them are available on the iOS store or the Play Store. And what do? Number one, they even enable you to track your menstrual cycle.
All right.
So when you miss your cycle, they probably send you an alert. And then they also provide you with option of what to do if you think you have missed your cycle. They will also probably tell you the kind of medication that you need to take. And the platform even also give you the early warning sign. What do you need to watch out for if you are taking the medication? If you are seeing this sign, then maybe you need to see a doctor. There are also part of it that even enable you to even check yourself to be sure that you are even eligible to take this medication. To be sure, for example, that you are not having ectopic pregnancy. What are the things you need to check out for? When do you need to seek counsel? Okay, who do you need to talk to? What kind of pain relief tablet you need to take? And then it will also end up by the kind of contraception that you need to take to prevent a recurrence of unwanted pregnancy. So it's a whole gamut of care that the app enables the woman to provide for herself.
Is this app initiated by Ipas Nigeria, or is it a general app by another external organization?
It's a general app. Ipas is part of it globally.
Okay.
It's not hosted in Nigeria, but we are part of it globally.
Okay.
So because we find out how do we support women, because it's easy for us who are in the city to walk across a doctor or walk across a pharmacy. But there are a lot of women in the rural area who do not have that luxury, or even having a doctor, or even having a pharmacy. There are states in Nigeria where you probably have just one registered pharmacist, or none at all. So how do we support? How do we provide services for such women? So that is what IPAS is trying to do globally. And then we hope that people will take advantage of this information. Like I said again, the Safe Abortion app or SA app, and also the Experian app. Both are available on the two platforms, Play Store or iOS Store.
Thank you very much, Dr. Palmer, for that insightful information. And it's really exciting to know, because it's going to save a lot of people from unsafe abortion, right? It's going to save us a lot from maternal mortality, what we are trying to avoid. We're going to go on a short break right now. When we come back, we'll be talking about the dangers of unsafe abortion, innovations and advocacy efforts Ipas Nigeria is doing to ensure accessible post-abortion care in Nigeria. We'll be right back. Welcome back. This is still the Voices for Self-Care podcast, and we're talking on navigating self-managed abortion care in Nigeria, policy, practice, and legal realities. We have in the studio the country director, Dr. Lucky Palmer. If you have missed the show for the while, you've really missed, and we have been talking about this very controversial yet interesting and important topic, and we are going to go on with that. So, Dr. Palmer, we have expounded a whole lot. We've talked about what abortion is. We've talked about the legal permissions, but I want us to expand on that further for those who are just joining us. What exactly is Nigeria's provision for self-managed abortion? Is it legal in Nigeria, self-managed abortion?
Interestingly, in our law, the only thing that is medical inclined that is included in our law is about abortion.
Wow, that's a very interesting fact.
Yeah.
I never knew that.
Every other medication treatment have been treated by the professional guidelines. And then sometimes I ask my learned friends the question, why do we have a law that is discriminatory against women? Because right now it's only a woman that can get pregnant, or somebody recognizes a woman that can get pregnant, right? So that is the only law in Nigeria, or the only thing we have in our law that regulates healthcare. So whether self-managed abortion or post-abortion care, there is no legal provision for it, just like every other medical treatment for different illnesses, including HIV, including syphilis, including cancer, including malaria. It's not in our legal books.
Wow.
So that itself should make us to ask questions. Why do we have abortion in our legal, which is just another health treatment? Abortion is health care.
Right.
It's not a moral issue.
Right.
So we need to first of all look at it from that angle. So legally, it's not in our statute book. It's under the purview of the professional management. So coming to that, and I think there is a huge space for the professionals. Even when you look at it within the law, the book, they've taken an oath to preserve life, but unfortunately, the law says they should only intervene when the woman is about to die. So if she's on the road to dying, they should not intervene.
Right.
So we should ask ourselves, are we tying the hands of our health professional to save lives? So that is one question there. But I think I think there's a huge opportunity for policy reform. And,
yes, that was my next question I was going to ask you, really, because you have just said there is really no legal provision for self-managed abortion in our Nigerian context. But aside the criminal code and the VAP Act that talks about accessing medical abortion under these conditions of her health and safety. So what policy recommendations would you make to improve access to safe abortion care in Nigeria? How can healthcare providers and policymakers, how can they balance this legal compliance with the need to support and expand access to abortion care in Nigeria? To abortion care, really?
Yeah. So there have been attempts to use the VAP law to expand access to abortion care, especially for survivors of gender-based violence. And that so depending on the state you find yourself, that enabled the woman to have access to safe services when it's needed. But it depends on the state you find yourself. I'm also aware that even the law, we're talking about the law, the Lagos law also have some other provision that also allow somebody to have access, including medical, self-managed abortion in the state. But I think beyond that is for us to really look at the policy space we have found ourselves. Looking at the law that we are even referring to is over 150 years old.
Right, 150.
Yeah, it was 1851 or 1861 that law.
That is outdated
in Nigeria. So the question is, most of our law have been updated. So how come this one is just there? Because as we always say in Nigeria, that we are a cultural and whatever people. Even though I'm not so sure that we are cultural, but that's another topic on itself. Okay. But the truth is, abortion is an health care. Some years ago, I think 22 years ago or 25 years ago, HIV/AIDS was seen as a cultural or an immoral sickness or illness.
True.
So it's not seen, you are not accepted in the community. But at the point when people see the effect it's having on the population and that people are dying, government leaders, policymakers came together and came up with a policy to destigmatize HIV/AIDS and make it a public health issue. And if you remember, even at that point, they have their own separate clinic. People say, oh, look at them, HIV/AIDS people. But now, people have come to accept it as part of our life because of science, because of medication. So self-managed abortion is about science and medication. So for me, it's about how do we also shift from where we are and embrace science and medication to treat people who find themselves with unwanted pregnancy. So one of the things that Ipas pride themselves in is expanding access to women who need abortion services.
Okay.
And we do it from the point of do no harm.
Okay.
What do we mean by do no harm? The woman is pregnant, the pregnancy is unwanted, most likely because she was raped or forced. So if you do not provide her with a safe option, she will go for a unsafe option. Either she died or she maimed for life. A few of them live to tell good stories.
Right.
So of what benefit is that scenario to the society?
Right.
When we have an option that is safe and it's cheap, compared to the treatment that might be needed if she goes for unsafe abortion. Can you stop it? No. And I know some people will say, well, if she does not want it, if she's not ready, she should close her legs.
Right. But that is, I would, in my opinion, that's a myopic statement, because not every woman who is pregnant was willingly pregnant, right?
Exactly. And sometimes I also ask this question when I have this kind of opportunity or conversation. I say, why do we think we have sex? It's part of adulthood.
Right.
You can't run from it. There are about 3 animals that have sex for fun in the world.
Okay.
You have the ape, you have the human, and the whale.
Wow. This is another interesting fact.
Every other animal, every other mammals only have sex when they want to procreate. If the female is not on it, the male cannot climb.
Right.
But the human, the ape, and the whale, we have sex for fun.
For fun. Wow.
So which means every adult is entitled to want to choose how she wants to have her fun. But the society must also be ready to give her whatever she needs to save herself and protect her. And I will come from another angle about this. When people say close your legs, a boy and a girl are in class, maybe SS2 now, the way it's called now. They are friends. She gets pregnant. The law says she has to stop schooling.
Right.
She has to give birth. But the boy continues her education.
Oh, that's unfair.
The boy go on to become a medical doctor. The girl end up selling groundnut along the road. So it's also a form of, it brings a form of gender discrimination because it has held back the girl from being able to earn education to compete with the male gender.
True.
So these are some of the things that the society have used to limit how the female gender are able to compete with the male gender in the society. And also, coming to the issue again about why she doesn't need to close her leg, it's her body, it's her choice. We need to give her that option to make a decision by herself. So for Ipas, it's about making sure that we give her that opportunity to make a choice, prevent her from going for unsafe abortion, but more importantly, use the opportunity of giving her abortion to now give her what we call post-abortion family planning, contraception.
Which is even aligned with the National Self-Care Guidelines.
Exactly.
Right.
Which align with the self-care and also prevent a reoccurrence of unwanted pregnancy.
Right.
And then if she's introduced to contraception at that point in time, she can also engage with her colleagues, with her friends, and also influence them, and then we can also prevent unnecessary deaths from unsafe abortion that is too alarming in our nation.
So thank you very much, Dr. Palmer, for that response. But I'm going to ask, this is a huge there's a huge cultural barrier in Nigeria concerning this, as we all know. So what is Ipas Nigeria doing to educate, to create some sort of awareness in society, to create more access and maybe acceptance of this concept of abortion, self-managed abortion, and even post-abortal care? Because we know that because of the stigma attached to abortion generally, it has limited access to post-abortion care. So what efforts or innovations is Ipas employing to create this sort of awareness in the societies?
So for us in Ipas, our work is rooted in community engagement.
Okay.
And also working with professionals. So we do a lot of community engagement. We work with traditional leaders, we work with religious leaders, we work with professional bodies at different levels, nationally, regionally, across West Africa and the world, using science and what we call value clarification to have engagement and conversation with leaders. It's also fun to us that we also work with the police.
Right.
We do a lot of training and engagement with the police.
Okay.
It's all about how do we promote women's sexual health care. I think that is the most important thing. Letting people understand that abortion is not a moral issue.
It's a health issue.
It is an health care.
Wow.
It's just as going for a malaria treatment. It's like going for HIV/AIDS treatment and all other forms of treatment in the hospital. And sometimes I say, people always talk about morality, and I ask, what is moral? Should you judge me by your morality? Before the slave masters came to West Africa, our people, our forefathers were very comfortable walking what we call now semi-naked. So by our own standard of today, are we going to say our forefathers were immoral by walking naked? By the ladies walking with their chests fully open?
True.
Are we saying they are immoral?
I hear you.
No, so we need to ask what really is morality? And then when do moral change?
Right, because culture is supposed to be dynamic, right?
Yes.
It's supposed to be changed in accordance to the society and what works for the society at the time.
Exactly.
Right.
So that, and because everybody tried to judge another person by their own moral lens, that's what brings conflict in our society. And if I happen to be the one holding whether political leadership or whatever, and I use my own moral lens to judge everybody in the society. So I think we need to first of all debase ourselves and say my moral is correct, and let people have the choice to make their own choice, the opportunity to make their own choice. So that's why for us it's about engaging with traditional leaders. So by the time we go through the value clarification session with most of them, we find out that between 80 and 90% of them always come to understand the reason why somebody might want to go for abortion. So you find a case where somebody, I remember there was a state in the north where a traditional ruler told us after going through the process, he said, well, if my daughter is raped and she's pregnant, she should not come and tell me.
Right. Right.
Even if I'm aware she's pregnant and she wants to go for abortion, she should not come and tell me. If I don't see her tummy grow bigger, I will not ask her what happened.
Wow. Just be silent about it.
So I think that is the hypocrisy that all of us try to play. So you see people who are in political leadership, who are religious leaders, when it comes home to them, when the chicken is fully roasted in their backyard, they deal with it in the backyard. They don't talk about it. But they come out in the open and they are against it.
So but let's talk about the future or the possibility of any change at all. I mean, we all know these things as advocates. We know that abortion is a health issue. It should be treated as a health issue rather than a morality issue. But the fact still remains that Nigeria did not adopt the WHO's recommendation. The fact still remains that the criminal code speaks against abortion. I mean, it just allows it under certain circumstances. There has to be some verification by healthcare workers to determine whether her life is at risk. So how do we put this into practice now? What efforts or recommendations would you make for policymakers to put this into practice? I want you to make recommendations right now. Let everyone hear you. What recommendations are you making to ensure that I mean, abortion should not be treated in secrecy anymore. Women should have access to post-abortion care regardless of, the level of abortion, the type of abortion, self-managed or medical abortion that they entail. Please go ahead, sir. Recommendations.
So I think my first recommendation is that we need to look at the low-hanging fruit.
Right.
I think we need, as a matter of urgency, to amend our law to allow for a woman who has been raped without being subjected to another rape by questioning to have access to abortion.
Okay.
And I would cite a very good example, Ethiopia.
Okay.
20 years ago, Ethiopia and Nigeria were competing on a race of who have the worst maternal mortality indicators. 20 years ago, Ethiopia took the decision to allow abortion for women who have been raped. Today, Ethiopia have reduced the maternal mortality to less than 200 from over 1,000. Nigeria used to be about 600 or whatever. Now, Nigeria is about almost 1,500 women per every 100,000. Just because they allow abortion for cases of rape, they crash maternal mortality. So now, Nigeria we say we want to crash maternal mortality. One of the low-hanging fruit is expanding access to safe abortion. Even if for women who have been raped alone, I think that would be great and to be a major milestone, and will enable us as a nation to save not less than 20,000 women every year.
Right.
And then coupled with other mammy aspects that we're doing, then we can really be talking maybe in the next 5-10 years, crashing maternal mortality below 200 from where it is right now, over 1,000.
Wow, thank you, sir. So your key recommendation will be to review our laws and to ensure that safe abortion they expand access to safe abortion for issues of rape, right?
Yeah.
Sorry, I'm gonna.
I also probably also add, my second one will also be that we need to rapidly scale up training of healthcare workers to be able to provide post-abortal care.
Very interesting.
It is important.
Very important.
So that because not just in the city in general hospital it's very easy because most likely might have a medical doctor who must have learned about it and may be able to provide the services. But when you go to rural areas where people are still using herbs or manner of things to reduce abortion, when they are lucky, like quote unquote now lucky, to get to the hospital, if the nurse in that PAC is not able to provide that services, most of them do not survive before they get to the general hospitals, which are miles away. Because before they get a vehicle to transport that person there, most of the time they turn back on the way because the person has given up the ghost.
Wow. So
training of healthcare professionals is important for post-abortal care.
Thank you very much, Dr. Palmer. I forgot to ask you one key question during the course of our conversation, but I don't think it's too late because to ask that. How do we ensure, or what effort is Ipas doing to ensure the safety of this product, mifepristone? Sorry, I always have issues pronouncing them. What efforts are you ensuring that these products are authentic? Because you mentioned that this is one danger that contributes to unsafe abortion. Yes.
So mifepristone is a very delicate medication. You can actually get a genuine mifepristone, but the way you store it could make it to lose its efficacy. The longer you stay, the more it loses its efficacy. So, for example, because PPMV are not allowed to store mifepristone by the regulation, except for I think for the tier 3 PMVs. Yes. So some of them that store mifepristone, remove it from the blister based on ignorance, so that they not store it in some form of leaflet, because they do not want the regulator, if they come, to say with them. So you have gone there, you have purchased mifepristone. It is genuine, but the efficacy has been greatly reduced.
Wow, because of the storage.
Because of the storage. So it is important that whenever you want to buy Mensoposter, you buy the right one in the right place. Always insisting you buy it in the package as packaged by the manufacturer. And if you go to the app, like the apps I mentioned earlier on, the Safe Abortion app, you are most likely going to see the names of genuine Mensoposter and genuine mifepristone there. And then when you go to buy, I think the ones that have been licensed in Nigeria, they also have the scratch number that you can scratch and call to be sure that what you're buying is authentic. I wouldn't want to promote a particular brand,
Of course, I understand.
on this show. But if you go to those apps, you are most likely going to see the different brands that have been licensed in Nigeria. And I think in Nigeria, we have a lot of, quote unquote now, unbranded Mensoposter in the Nigerian market that are not licensed.
Yes, so that's
people
why
need to
is
be
it
conscious about
accessible over the counter in Nigeria? I don't
So
think
that's
it's
why I talk
accessible
about
over the counter.
it's not easily accessible, and I think that's so. In terms of promoting for self-care, I think there's one area that we need to work. And one of the tax shifting, tax sharing tried to do is to increase accessibility for Mensoposter on the counter through the accredited PPMV who are allowed to store it. So I think that has reduced some bottleneck there for Mensoposter. But the mifepristone is still being sold strictly by prescription, and that is at limited access to people for people to buy across the counter. But I think there are ways that people are getting this medication.
Which we do not want to say to you now. Thank you very much, Dr. Palmer. This has been a very interesting and engaging conversation. We talked about all the serious stuff. We talked about all the serious legal, yes, do this, what are we doing? Now it's time for us to loosen up and play some games.
Oh, that's interesting.
Yes. So on the show, on this new season of the show, we're going to be playing a game every episode rather. And this game is called Two Truths and a Lie. The rule of the game is simple. I'm going to make 3 statements, and our guest here, Dr. Lucky Palmer, is going to find out which one of these statements is a lie. Are you ready, sir?
Okay, I hope I'll pass.
Yes, definitely. You pass. This is about self-care. So every statement I'm going to make is about self-care. Are we ready?
Yes, let's go.
2 truths and a lie. I'm going to make 2 statements. The first statement. Over-the-counter oral contraceptive, OCP, are to be made available without prescriptions for individual using them. That's one. Secondly, self-administered injectables contraceptive should be made available as an additional approach to individuals of reproductive age. 3. Self-care means you can ditch the health centers and self-medicate all on your own. Which of these statements is a lie? Your time starts. You have 5 seconds to answer. Your time starts now.
I think I'll go with the number 3.
Self-care means you can ditch the health centers and self-medicate all on your own. Final answer. This is a lie?
Yeah, I think it's a lie because for some time you will still need to go to the health center.
3, 2, 1, and I'm going to reveal the answer. Okay, so our correct answer is number 3. Dr. Palmer was right. Please put your hands together for me wherever you're watching from. Self-care does not mean you can ditch the health centers and do self-medication all on your own. Self-care, however, means that you can prevent illness, manage diseases with or without the healthcare provider. Right. However, there are provisions. It's not all self-care interventions that you can do on your own. Some will require that you have to access the health provider first, and then after the healthcare provider, you can now continue self-management on your own. Thank you very much, Dr. Palmer, for gracing the show today. It has been so exciting and it's been enlightening, interesting, and I really value all your insights. To my esteemed viewers, many thanks for joining us again on this show. This is a Voices for Self-Care podcast season 2, and this has been exciting. If you have any questions for Dr. Palmer, please send us a message right there at the comment section, or send us an email to rancoms@gmail.com. That is warncoms@gmail.com. I'm your host, Oyare, and I will always see you next time. Bye.